welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Rebecca Sapp. I'm a board-certified allergist and immunologist and a fellowship director who always enjoys learning more about the exciting field of allergy immunology. Our podcast series will use interviews with thought leaders from the world of allergy and immunology to keep you up to date on new developments and review core topics. Today, we'll be discussing new treatments in the world of chronic idiopathic urticaria. This is a common condition we see in the allergy clinic, and most patients will respond to high-dose antihistamines. For those patients that don't, it's great to see new treatments on the horizon, including a small molecule that would give us an oral option for these patients with severe disease and may teach us more about the disease itself. We are pleased to welcome Dr. Romi Saini. Dr. Saini is a professor of medicine at the Johns Hopkins University School of Medicine and the Allergy Fellowship Program Director there. He has served as section editor for Allergy and the Journal of Investigative Dermatology, and is the current editor for the Urticaria, Angioedema, and Mast Cell Disorders section for Up to Date. He is a past member of the FAAAAI Board of Directors and is currently serving as co-chair of the Joint Task Force on the Urticaria Practice Parameters. Dr. Saini, thank you so much for taking time to join us today.
Happy to be here. Thanks for the invitation.
We always like to get to know our guests a little bit better. Could you tell us a little bit about yourself and include something you like to do outside of medicine?
So, as you may know, I've been in the field of allergy for a few years and been happily serving, like you, as a program director, but for a few years longer. So, certainly I've been doing this for 17 years now as a fellowship program director. But outside the world of allergy, what I like to do is spend time outside. And so I'm not only somebody who enjoys being out in the garden, I'm pretty proud of what I put together every summer since this is the summertime. I'm also a fairly avid fan of all the national parks. So whenever I can, I'm probably happiest in a park location on a trail hiking somewhere. So that's really what I like to do when I'm not sitting in this office and doing the business of allergy.
Do you have a favorite national park?
That's a tough one. That's a tough one. I like the varied natures of national parks. I think I really like the Volcanoes National Park in Hawaii. I've had the opportunity to see a few in Alaska, and just the large variety. I think I was just so impressed with the height of the mountains in Alaska. I think that, and they just go on for forever, and that to me was incredibly impressive. So hard to pick. Hard to pick.
It is hard to pick. We went to Yellowstone and Grand Teton last summer, and I had one of the most beautiful hikes I've ever taken through Cascade Canyon and Grand Teton. So that may have taken over as my favorite.
That's the first. Gotcha.
Yeah, but you're right. The varied nature is so incredible. Well, what made you choose allergy immunology as your field?
Well, I think a lot of us, like our patients, suffer from allergies. And I think I was an unrecognized allergy sufferer when there wasn't a whole lot to offer. And being an outdoors person, I was always the one that, you know, blew through a box of Kleenex, cutting the lawn. Used to have these dry patches on my skin that I never really understood. And then, just felt really sedated on the therapies that were available when I was a kid. So it really had an impact. I did try to muddle through doing what I could do, but obviously felt terrible on the treatments that I had to take as someone who had hay fever and likely eczema in hindsight that I just didn't understand.
Yeah, a lot of us come into it wanting to take care of ourselves or our family and make things better for them.
Absolutely.
So we're going to talk about chronic idiopathic urticaria, and it's a disease that many of us see kind of on a daily basis. But even now, years later, the underlying pathophysiology isn't really well understood. How do you explain it to patients what's going on?
Well, I think every patient that we see always suspects something that dramatically is changed in themselves. They're suddenly allergic to something that they're eating, that they're using as a product, what have you. And I think this is time where we have to ease that high concern that it must be something, because they can almost pinpoint almost the exact day that things started for them. So what I really try to explain is that while When we see hives, we often think of maybe a food or a drug allergy. In the setting of chronic hives, when it goes on and on for several weeks to days, we are more suspect that it's an internal process. So I try to say it's a change in the sensitivity of your skin. Your skin has now moved into a heightened spontaneous reactivity phase. And if possible, sometimes I try to demonstrate it, just simply with a scratch of their skin. So I'm almost always doing a dermographism challenge as a way to say, hey, you haven't eaten something, you haven't done anything, but with this simple scratch, I can see that your skin is in this heightened state of reactivity. That's how I try to get people to focus less on what is the external trigger, but what might actually be going on in terms of that this is an internal process of heightened change in their skin.
Yeah, it's amazing. Patients spend so much energy really trying to figure out what is that thing that I'm allergic, and they often have these like long logs of things they've been exposed to and trying to explain to them it is nothing that you're doing from the external side. This is something that's going on inside of you.
That's right. That's right.
So the first step we often try is just really increasing their antihistamines, these second generation antihistamines, getting them to high doses. How do you typically escalate antihistamines in patients?
So I think the trend, going back for me now, probably the 2007 guidelines or thereabouts are the first time we started putting that into the guidelines using a non-sedating antihistamine at fourfold the labeled dose as a maximum. In my practice, I typically start, if they're not on any, I just start with the simple daily, but I give patients the permission to escalate. And I typically say between 1 week to 2 weeks between steps. So I let them experience control for a week, but I don't want to wait forever. I think some people move much more gradually through the steps and stages. And I think I just think about the fact that only about 20% of individuals with chronic spontaneous hives will come under control with a single tablet of antihistamine. At least that's what the literature tells us. Why do you want to go 2 months at a time with letting this person suffer with a very slow escalation? Again, 1 week steps is what I most typically do.
Yeah, absolutely, because it really impacts their quality of life so much, and so getting them to a dose that we know is, may help them is so beneficial. And then if that fails to control the hives, we often move to other treatments in kind of the stepwise manner. What medications would you reach for when you've really escalated the antihistamines to a dose and you're just not seeing the effect of those? What would be kind of your stepwise approach?
So I think I've been practicing long enough. I'm very familiar with what I call the US kitchen sink approach. A lot of people move to H2 blockade, people move to LTRAs, a leukotriene receptor antagonist, and maybe, some of the older sedating antihistamines. I think my practice has changed. I know that was on the table based on the 2014 US practice parameter guidelines. And we've been busy looking at the evidence basis for the add on benefits of a lot of these various agents, and even what will be seen when you updose an antihistamine. Where do you get the greatest bang for the buck? But to more directly answer you, I think I'm moving much quicker to the use of, I think, the other or the first biologic approved for chronic hives, that's omalizumab. So I tend to move fairly quickly, and I'm really using both the patient's reaction or response to updosing antihistamines as a guide. I'm also doing some scoring. A lot of people are very familiar with this, but we tend to do UCT scoring in my clinic to help guide how great is the impairment for an individual to make that decision. So I'm streamlining a lot faster to going to omalizumab, just given the past stories with the use of these other alternative agents.
Do you find yourself subtyping them or using lab work to try to get biomarkers to subtype them into kind of we have this idea of an autoallergic versus autoimmune. Do you tend to do that early on or wait until later on when you're kind of choosing the whether or not you use a biologic or think about immunosuppressive therapy?
I think I find myself regularly now as I see my patients. We usually do a basic battery of workup, a CBC, CMP, but I'm typically looking for other values. I'm looking at that CBC and differential more closely. I'm looking to see, do they have a low percentage or absence of basophils or absence of eosinophils? Again, these are hinted at as being somewhat of the subset that may have more an autoimmune, in quotes, flavor. I also, besides low IgE, I may look for evidence of other autoimmunity based on a lot of the patient's history. I mean, do they have a story or a family history of thyroid autoimmunity or other autoimmunity? I may be also, drawing those inflammatory markers, either ESR, CRP, or looking for thyroid autoantibodies and just balanced thyroid function as part of my initial evaluation. I think we're getting to a point where we're starting to see groups of patients that tend to respond differently, particularly to advanced therapeutics. And it's best to draw the blood up front if you think someone's gonna have more refractory disease that they're gonna move on to an advanced therapeutic, then wait, because once you start those advanced therapeutics, you may alter one of those key values, which is the IgE value. So I tend to do it earlier now, and I do start thinking and clustering individuals in terms of biopredictors.
And then omalizumab binds IgE, as we know. And we've already talked about that this is really not an external trigger from an allergy. How do we think omalizumab is working to control the hives?
So I think getting back to the idea of heightened spontaneous reactivity of the skin cells. So we see evidence again that the mast cells seem to be heightened in their reactivity as demonstrable by simply, as I mentioned, a dermographic challenge. We have other data to suggest that the mast cell is more responsive in general. And again, it tends to be focused mostly on the skin, but in doing inventory of symptoms, we also have people that have frequent reports of extracutaneous complaints. They can report, sometimes joint pain, stomach pain, some respiratory symptoms. So we do have in our more severe patient population the possibility that they could have extracutaneous complaints. But I think in terms of thinking about how does IgE play a role, we're now very familiar that we have to dose omalizumab very carefully if we're dealing with an allergic disease. We look at that IgE value and we try to lower IgE greater than 90% based on a weight and an IgE calculation. Not the case with chronic hives. We can use a one size generally fits most people approach. And in fact, it seems like people with higher levels of IgE may actually respond better than at the low end of the spectrum. I think that points us to a different role for IgE in this disease. Is IgE somehow contributing to the spontaneous reactivity of the histamine-bearing cells of the body? We can see both mast cells altered in behavior, and we also have evidence that the blood basophils are very altered in people with spontaneous hives. And I believe IgE is conveying a sense of heightened reactivity to those cells in people with active disease.
Yeah, and by downregulating the high affinity IgE receptor, we may actually be really quieting those down.
Yes, I mean that's definitely an effect of omalizumab binding IgE. It lowers the receptors on both of these cell types. Absolutely.
And then dupilumab is now recently approved for chronic idiopathic urticaria as well. And it seems to work on a similar group of patients than omalizumab, although it targets IL-4 and IL-13. So a different mechanism. How do we think dupilumab is working in these patients?
So, we've seen and learned a lot about IL-4 targeting and IL-13 combined targeting with dupilumab. I think we have to understand what these cytokines might be doing in a disease like CSU. And I think there's evidence that both of these cytokines are very important for the recruitment phase of cells coming into the skin. So we see evidence that blocking these may impair the arrival of the critical cell types into the skin. So, are we actually quieting the mast cell, or are we quieting a step in terms of the recruitment phase, the infiltrating phase of a hive? And I think the evidence is still not absolutely clear where exactly we're interfering, but one of my ideas is that it might be that we're impairing the recruitment phase. We see a gradual onset of relief with dupilumab. I think than what we see maybe with some of the other therapeutics, and it may be that it takes time to get those pathways shut down for relief.
Perfect. And then the new medication that's looking very promising are these BTK inhibitors. Could you tell us what exactly is a BTK inhibitor and why do we think it's going to work well for urticaria?
So, everybody in allergy learns about BTK deficiency or absence as a disease. So, BTK is an essential signaling molecule that's just downstream of the activation of the Ig receptor pathway. So, BTKs are found within BTK. This tyrosine kinase is found within mast cells and basophils, and of course, B cells. And so, why do we think it's working or why do we think it's helpful? We again think that, acting on the Ig receptor via omalizumab has brought relief to patients. So moving not so much on the outside of the cell, unburdening the cells of IgE, but actually the activation process of the Ig receptor makes great sense if you're thinking about another way to tackle the problem. So I think that's where BTK inhibitors play a role. And how are they working? I think very much we see that mast cells and basophils are both impacted by omalizumab. BTKs also target mainly those two cells in a very rapid fashion in terms of inhibiting the IgE pathway.
But the BTK that's being impacted isn't any different in the mast cell or basophil versus the B cell. We're targeting the same molecule.
We are targeting the same molecule. We don't think that there's a difference among these cell types.
Yeah.
Correct.
And now in these studies on BTK inhibitors, knowing that impact it can have on B cells, are there any safety signals that have been seen that we're concerned about?
Yeah, so the obvious thing is there an impact on immunoglobulin levels, and that has not been seen, or risk for infections above and beyond what we were seeing in the trials and placebo populations. That hasn't been seen as well. There's some newer data that are coming out in terms of vaccinations. Will vaccinations be impaired? And I think the early data sets are telling us no, that isn't the case either. So there is going to be an impact on the B cell compartment. I think the data is just starting to emerge. Are we going to see a selective impact on the B cell compartment, particularly with the idea could there be an impact on autoantibodies in particular that people may express? That's always been the thought that there may be a preferential effect on B cell production of autoantibodies.
And is that because the dose that's needed to inhibit the mast cell and base cell is just lower than what we would need to also inhibit the B cell, or that we need to inhibit the B cell longer before we would see that? Why aren't we seeing an impact on the B cell?
No, that's so I think BTK is not a target found in plasma cells. We're seeing plasma cells, the factories of immunoglobulins in our bodies doing just fine, and we're not seeing a global effect.
Mhm.
It's the B cell production of specific antibodies that may be being affected. Again, I'm speaking in advance of some of the data that's likely to appear coming out on what's happening specifically at both vaccination responses and specific autoantibodies. I don't think it's a dose effect necessarily. I think the same enzyme is found in all of those cell types, but we see a very rapid onset of inhibition, um, as you were mentioning, to the mast cell and basophil very rapidly. Literally, within a few doses, you can see that their Ig pathways are inhibited significantly. Um, Again, the B cell is a longer readout and longer time to a readout. Is it just that it takes longer for us to see evidence of an effect?
Yeah, I think there's uh, some studies going on in food allergy where you could even use a couple of doses of BTK inhibitors and really inhibit the response very rapidly.
Absolutely. We've seen that a few doses of a BTK inhibitor can inhibit not only the skin test response to a food allergen, blood basophil bat testing, basophil activation testing gets shut down very quickly. But clinically, oral food challenges have been shown to be successful within just a few doses of a BTK inhibitor. And the model I'm discussing is in, say, adults with peanut allergy. We've seen great success in their ability to be able to eat peanut within a few doses of a BTK inhibitor. So it's quite exciting that this may have another avenue that we may be using these types of pathway inhibitors.
Yeah, absolutely. It's a really exciting medication that could be used in so many different areas of allergy. Yeah. So you were involved in the Remix 1 and Remix 2 study that were recently published. Can you tell us a little bit about the study, what it was looking at, and then about the data?
Sure. So these were worldwide studies, again, enrolling folks or patients, excuse me, that had antihistamine refractory chronic spontaneous urticaria. They were given the the tablet of remibrutinib twice a day at a dose of 25 milligrams in a double-blind fashion for roughly 6 months, and then the placebo group was converted over to open label therapy, and the entire group of subjects experienced around a year's worth of treatment. So a couple of call outs about the patient population. I think they were, as we typically see in urticaria studies, more females than males. We also saw people that had long-standing disease, so they typically have had disease for several years. But we also noted in this population there was a specific um, recruitment or allowance of individuals who had previously tried uh, anti-IgE therapy. Most of them were omalizumab experienced. Some may have been experienced also with ligelizumab, and this was capped at around 30% of the patient population. So I think these are some of the unique features that were seen. And in terms of what was seen, as compared to placebo, as early as 1 week under the double blind treatment, we could see that the folks receiving active therapy had a significant reduction in their urticaria activity score as compared to the placebo group. So I think what was remarkable was that we were seeing this fast onset of effect. And again, it continued so at both the 12 and 24-week endpoints of the double blind period. So we were seeing fast onset of effect, significantly greater than the placebo group. And I think this was consistent across the two main studies, Remix 1 and Remix 2.
And really exciting because this is a population of patients that sounds pretty refractory, given that they'd been on anti-IgE therapy, they'd been on high
Mhm.
dose antihistamines, and really not having benefit from that. So, a really exciting result.
That is correct. I think people are always looking for what they can do better for their patients. And, while lots of people respond to omalizumab, there is a population that doesn't, and we're seeking something else for them as an option. And again, 1 out of 3 individuals roughly in these trials were omalizumab experienced and not fully controlled. So we are seeing benefit to that population. And it was very similar between those who were anti-IgE naive and those that were anti-IgE experienced.
Perfect. And any safety signals that we're seeing in the trial?
Yeah, so one of the things that was being looked at, of course, were infections, antibody levels, and those were not seen. There was no petechiae,
Mhm.
um, minor in incidence and occurrence that would occur periodically through the treatment with the active compound well, not much higher, but significantly higher than placebo. And these were not directly linked to changes in platelet counts, and they weren't persisting, so they tended to be a blip and then they would resolve. Um, there really wasn't many people that stopped therapy as a result of it. It's just something that was observed through the course of the studies.
Huh. Is BTK involved in platelet adhesion or anything like that?
Yeah, so I think the effect on the linkage between platelet number, platelet function, and the petechiae is been puzzling. So there wasn't evidence that there was clear-cut reductions in platelet numbers, which is typically what we think of when we think about petechiae. So it's a
Mhm.
little bit unclear how to link the occurrence in some individuals when it didn't seem to completely mirror what was going on with their platelet compartment.
Fair. But it doesn't sound like there were any concerning serious outcomes.
No, there was not serious bleeding, hemorrhaging, things like that as a result of the use of the BTK inhibitors.
And was there, I don't know if it was looked at like IgE or any of these markers that people are using to kind of subtype the chronic idiopathic urticaria, if there was any difference in how patients responded in these different groups to the BTK inhibitors.
Yeah, no, that was definitely something that was looked at, and we and others have been involved in studies that look at lower IgE baseline levels as maybe being negative predictors for response to omalizumab. So there was some subsetting of the population in terms of IgE levels, and there hasn't been a clear difference in low or high IgE groups in terms of response characteristics.
Mhm.
There's also been some evidence or some data, some of it ours, that if you look at baseline presence of a CIU index positive assay, this is a serologic assay tested against normal basophils for the serum of a patient to cause histamine release. Um, that assay was not found sorry, that assay positivity was not found to be a negative predictor, and perhaps even it favored, in BTK inhibitor, studies, a positive response to the compound.
That's great. So, in patients who may not be as likely to respond to an anti-IgE therapy or possibly dupilumab, the anti-IL-4, IL-13, this might be a great option for them um, in terms of treatment.
Absolutely, and again, as you asked me earlier, collecting your baseline parameters on individuals with more, I guess, refractory hives may pay off. It may help you move to more selective therapies. Offering a therapy that may uh, be better for an individual patient who has one or two characteristics that may be less favorable for, say, an omalizumab response may make you move forward. And then certainly folks that have tried and not gotten under full control on omalizumab, this may also be an option for them to move to.
Yeah. And we were talking about BTK inhibitors may be kind of a great medication in food allergy. Are there other areas in allergy immunology, kind of in these allergic conditions, where you see BTK inhibitors really playing a role?
Yeah, so I think it's quite obvious that based on the small studies of BTK and food allergy, that that's an obvious place to go. But anything where you may want to have inhibition of the mast cell. So, one could move towards individuals who suffer from, say, idiopathic anaphylaxis or other types of mast cell disorders, because this is something that could have very quick onset. I know there's been thoughts of studying it in airway disease. I don't think the data has always been clear cut in that fashion, but some BTKs have shown promise even in something like asthma. So I feel like we're likely going to see the food allergy studies, which are already getting planned and launching next, given the rapid onset of effect. But we could think of anything where we put the mast cell at the center of a disease as something that could be targeted.
We've talked about it even in drug allergy. So you have these patients that need a desensitization
Yeah.
for a drug they're allergic to, whether it's for their cancer therapy and they have an allergy to a platinum agent, or they have there's just you see all the possibilities where this could really play a great role.
100%. I think giving rapid protection against a possible IgE pathway offender for an individual patient in drug allergy is that perfect example. Could you offer some additional safety to doing a desense
Mhm.
by giving a dose or two of these BTK inhibitors to ensure safety?
Yeah, since they work so quickly, you can see
That's
where it would just be so nice to have. Um,
absolutely.
are there other molecules that are being looked at for chronic idiopathic urticaria?
Yeah, no, I'm very happy to say that the space is very active these days. So I think besides BTK inhibitors as an oral therapeutic, we're seeing both injection and oral therapy that blocks the c-KIT receptor on mast cells moving forward as a therapy. So we've seen anti-c-KITs. show promise in both individuals with chronic spontaneous urticaria as well as inducible urticaria. There's a couple of antibodies making their way through, as well as an oral target of the c-KIT receptor. And I think exciting to people who are fans of both drug allergy and general skin disease, like I am. There's another receptor, MerG GPRX2, X2, which for a long time we didn't understand exactly what it did. It's the receptor for at least the compound 4880 we've known for years in allergy, and it is something that we think is higher in skin tissues of individuals with CSU. It can also be a receptor for several drugs. And so this MERGX2 pathway is now being specifically targeted by oral agents, also in trials in both chronic urticaria and inducible urticaria. So that's quite exciting. So I see movement in these two areas gathering speed.
Yeah, that's super exciting because it's involved in things like vancomycin reactions, possibly contrast reactions, things we see commonly that if we had a treatment that we could give someone before they needed this medication, it would be phenomenal.
Absolutely. No, it's very exciting, and I think we're gonna be rewriting our guidelines a few times, I think, in the upcoming years based on what we're seeing currently in the landscape.
Yeah, there's this idea that we need more living practice parameters because things are moving so rapidly that,
Yeah.
5 years go by and the whole landscape has changed.
I think that's the lean that we're going towards in terms of producing this current set of practice parameters, that we expect that this will be more a living document that can be periodically updated as things come into, the domain of possibly usable, for a patient.
Well, this is fantastic. Thank you so much for kind of reviewing all of this with us. Are there any take homes you really want to make sure that people come away with?
Yeah, no, I think the main message is we all see patients with chronic hives, and at one point, it would be frustrating because we always spend time trying to tell them it isn't something that they're seeking in their house or in their diet that's a trigger factor. So I think that's a big take home. But number two, I think given the newer therapeutics, some of which are very familiar to allergists as options, I think moving a little quicker, particularly in your severe patients, to these therapies not only brings relief to your patients, but it also gives them hope that, hey, there is something that can relieve this. It won't be going on forever at this high level of symptoms. I think that's probably the second message, that there's a lot of new therapies that are emerging. And, I think we just have to hold tight and gain our comfort and experience with each one as they come out. And as I think we talked about a little bit, is there a way to better target a particular therapy for a given patient based on their past experience or maybe something in their blood? And I think we're getting there very quickly to say we can use some of these early blood tests to help guide how we might pick a therapy for a patient.
Absolutely. Another great example of why allergy immunology is such a fantastic field as we move forward.
100%. I fully agree with that. Absolutely.
Great. Thank you so much.
Thank you.
We hope you enjoyed listening to today's episode. As a reminder, this podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence based information. Any questions pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board certified allergists in your area. Use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at their website. Please visit quadai.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to rate and subscribe through wherever you download your podcasts. Thank you again for listening.